One. So, but the second generation device included Sapien XT, S3, Core Valve Evolute, and Lotus. Actually, we have no cardiac death, no emergency surgery, no stroke, no permanent pacemaker. Actually, no private complications. So, we feel that we are very quite comfortable to extend this technique to a patient with a low risk, but there is a lot of debate from surgeons or the other doctors not involved in the TAVI procedure. So what do you think? I'd like to hear the advice from the panels.
I'm Hyeon-Cheol from Severance Hospital. I came a little bit late. Is there any particular reason to choose core valve in this case?
Actually, this lesion is quite simple lesion in the low-risk patients, and it is doable with both devices.
Septal bulge.
Yeah. Another point is that the septal bulge. I'm not sure any of you are very concerned about the septal bulge. Dr. Park, Sung-Ji Park, will you show the TE about the septal bulge?
Yeah,
so that's the reason why I chose core valve, but I'm not sure this is a reasonable approach for that.
in transthoracic view
yeah. T on the screen,
Could you
please?
show us the image?
Echo image,
Echo image.
TEE
Okay.
on the
We have the
screen.
image.
Okay.
Yeah.
Dr. Park?
T should here is the septal bulge. Maximum thickness of the septal bulge was 1.7 centimeter. And is the color showed color acceleration was developed due to the septal bulge.
Yeah.
So actually, initial experience, we tried to of the Sapien valve, balloon expandable valve. We tried to avoid the very large septal bulge due to a risk of the embolization, migration to aorta. But as you know, the core valve evolute has an advantage to recapture the valve. If it is too high and the migrate to aortic valve, we can recapture anyway. So it's a benefit, advantage of core valve for these patients. But I'm not sure this kind of septal bulge is really indication for the recapturable stent or not. What do you think?
So we measured the transthoracic and transesophageal echo. Is the aortic valve area was 0.7 centimeter.
Based on the LVOT measurement.
Yeah, based on the LVOT.
The fluorescence resistance.
Yeah.
So valve area is the theoretically correct.
Yeah.
And do you think the pressure gradient is higher because of the septal bulge?
No. So
contribution of the septal
LVOT dynamic LVOT obstruction was developed, but mean pressure gradient of aortic valve was 55 millimeter mercury. So severe aortic stenosis was also developed. Yeah.
I mean the contribution of LVOT.
So a little bit.
A little bit.
Yeah.
So the pressure gradient, the slide on the screen, please. There is no pressure gradient for that?
So that is the dynamic LVOT obstruction. Is the lasting is in lasting state. We didn't see the LVOT obstruction. After Valsalva maneuver, dynamic LVOT obstruction.
Okay.
Yeah.
What is the degree of the AR now? AR is minimal.
So
mild
I'd like
or-
to show the angiogram today.
AR was moderate. 저거요.
Yeah.
Okay.
Yeah, it was moderate. Yeah. This is very comfortable situation for us, as you know. If we have AR, but this is not acute, so patient tolerate more. So, but this is low-risk patient, so our target is a perfect procedure without any significant AR, less than mild or minimal is our target.
But a few calcification on the lip lid is another limitation for the good implantation of the core valve.
For low-risk patients, the interesting history is about the left main stenting. Actually, in Europe, they started the left main stenting very early, but usually they're implanted for the very high-risk patients. They're not amenable for surgical procedure. But in Korea, Dr. Park started the left main stenting for the low-risk patients first, really normal LV function. We have a very good result. So if you have a very good result, we are not worrying about the durability of the stent valve, so there is no reason not to implant the TAVI procedure, TAVI valve.
So Dr. Gwon, are you going to pre-dilate in this patient, or
No. Usually recent
Recently, we don't have.
recent 20 to 30 cases, we have never pre-dilated.
okay, please proceed with the
Yes,
procedure.
even if pressure gradient is more than 100, usually we don't need a pre-dilation. Okay?
Okay,
Okay,
please
we are
proceed.
exchange.
Dr. Kyuk-jang,
Dr. Gwon, I'm still concerning about the position of
Actually,
the pigtail.
I'd like to point out that,
Position of the
but,
pigtail catheter is not
I don't worry
in
about the
the
pigtail
correct
position. Just looking at the calcium, not looking at the calcium, just lotion, because the challenge about the core valve is alignment of a valve and the cusp together. Actually, in this view, the original view 좀
AP.
Yeah, this is original view for the alignment of three cusps. You can see the valve itself is quite not aligned. You can see the elliptical. So we are the decrease the LO view. IP로 올려. So you can see a better alignment. The NGO 마지막 거. So the elliptical alignment for the valve itself is improved, but the cusp is not aligned well. So we are doing the procedure in between. Okay? So we are proceed.
I think you better reposition the pigtail.
Test the lip.
Yeah,
Test.
Okay.
Yeah. Yeah. Okay. So pull back a little bit. Okay.
아직은 그대로 있습니다.
네.
풀백하시.
Okay. Okay. Blood pressure is still the blood pressure on the you can
Slowly.
see the slowly and faster. A little bit more faster. Okay.
Slowly.
Yeah. Blood pressure is compromised. It's moving. Okay. Okay. Now it's a working position. You can see LVBB now. Too deep? Okay, angel. Angel. Sure.
Looks okay.
Looks okay, but a little bit deep.
Yeah, a little bit.
Deeper than usual practice for us. It's for me it's 6 millimeter. 6 millimeter in the downward, about 7 to 8 millimeter.
So in our usual case, we deploy a little bit higher in.
So maybe layover, the
Okay.
proximal portion can
Yeah.
be covered.
Yes,
So
okay.
there is no permanent the complete AV block, and we can position.
Okay, sure.
Okay, the layover, the push the wire, and push the stand. Yeah, proceed.
Okay, here.
Yeah, proceed.
Deploy.
계속 deploy. Deploy.
Okay.
Okay.
Let's go.
Okay, I'm pushing the valve a little bit
Okay.
more.
Here.
Okay, to pull out the valve. Okay, still LVBB, but there is no complete AV block. Release the wire.
에코.
Okay,
에코 좀 보여주세요.
Then TE measurement is very important. So show me
So-
TE. TE on the screen, please. Where is it? TE on the screen, please.
We don't have T image.
Okay.
Maybe you better remove the
박
pigtail
실장님.
from the valve level. The pigtail.
Okay.
뽑아.
네, 잠깐만요.
So T showed the large paravalvular regurgitation from the LCC side. Yeah.
Turn up. Okay. Turn up. Okay.
So actually, this is not. This was not expected, right? So the calcification was not severe.
Yeah. Right. So the short axis view. Maybe we need
Yeah,
a post
I don't
dilatation.
want.
Actually, the measurement measuring of annulus is quite challenging, and so actually the inner size is in the middle of the sizing profile for 296. So I didn't worry about this. So this is not expected. You're right.
So this.
So maybe you can move around from the fluoro.
The
to,
paravalvular leak
yeah,
on TE
okay.
is more than mild, or
Okay.
what do you think? Is
Yeah.
moderate?
Oh yeah, it's the
Okay.
this is the by the circumferential extent mild to moderate because it's the 10.20% of the circumferential extent of the paravalvular regurgitation.
Actually, what I have learned from the procedure is we have to wait for 2 to 3 minutes for echo specialist to fully analyze the data. So we'll wait a little bit more.
So are you going to measure AR index in this case to decide whether you are going to post-dilate, or would you?
So if TE is okay, we are going to measure the AR index because we need to pull out the valve completely. But T is not okay. We are going to the post dilatation again. Then we measure the AR index afterwards. So you think the
T
AR
should
is more than moderate?
mild to moderate, yeah.
Mild to moderate.
Yeah.
Can you show the subvalvular structure? I mean, the
So-
LVOT for the septal bulging and the distance from the stent struts?
Yeah, long axis for
Yes,
septal
wait a
bulging,
moment.
please. Actually, we checked the sedangio on the screen. We checked the most frequent cause of the AR by the stent is eccentric expansion of the core valve. But if you see the calcified lesion, of course, not like this case. But as you can see here, we cannot see the expansion is complete. So I'm not sure another ballooning will help. So we check
32.
32. So we checked the AL index. Index is 0.32. So
Good.
more than 3 is good.
Good.
But still, in geography, there is a lot of AL. So maybe we can do the post-dilatation anyway. The wire. So mostly, this concentric expansion, I'm not sure the benefit of additional ballooning or not, but I'm curious about that. We can do a more complete result, the reducing PVL by additional.
So which size of balloon would you use for the post dilation?
Yeah, we're planning 22. 볼륨을 빨리 줘야 돼, 좀 세.
볼륨.
이렇게 빨리 가지고. 볼륨 빨리. Meanwhile, we have to check the pacemaker. Okay, 와이어 잡고.
해봐. 페이스메이커.
No.
180.
Yeah, just to 180 maximal output. Okay, pacer on. Okay, yeah, pacer off.
얼마까지 하는 거? 어?
Okay,
아니, 이거 프레셔 말이야.
good.
뭐라고?
Okay, 들어갈게. 와이어 잡아요. 와이어.
준비가 안 돼서.
괜찮아?
했어, 테스트?
됐어. 물론 몇 개월인 줄 알아?
20.
Yeah, just like Sapien 3. Okay. Pacer on.
Isn't it a little bit
Okay,
deep?
inflate.
Okay, 4, 5.
Okay, and pacer off. So what's the question?
I mean, the depth of the balloon.
Balloon 뽑고.
If you're worrying about the subvalvular, the narrowing or the bulging. I think it's just, looks okay, but I think it's better to
Just implanting
Be
the
cautious
annular
not to
portion,
deep, yeah.
covering annulus.
yes.
Yeah. Do you think there is some dissection risk?
Yes.
식테이라고 아무래도.
I think basically the valve is undersized. If I can see the cause of the AR in this case, there is less calcification. So only reason the position is not so bad, and the only reason is undersizing of the valve for this patient. So I don't worry about the dissection. So how about TE? Was it improved or not? Actually, I don't expect much.
네.
Yeah, T showed a similar grade of the paravalvular regurgitation from the
Right.
RCC after the balloon dilatation.
AR index 다시 하죠. So the angle. So actually, this patient is 84 years old, and the most people at 84 years old does like to go to surgery. That's why actually. And we had a very good result so far. So, and again, the AL is moderate before the procedure, so it doesn't do no harm for the patient. So I'm checking the AR index again. AR index was 0.34, 0.02 improved. Okay, anyway, I think there is no way to improve the result, and I remove the pigtail and get the final angiography. Okay, this is I think the best thing we can do. So I agree with the surgeon and said that this result should be more perfect, but quite acceptable considering the condition of the patient. Okay, 좀 빼고. Okay. Not that much. What do you
It's good. Well,
What do you think? the original angio, please. Original angio, please. We use the same amount of contrast and 제일 처음에 same amount of contrast, the same
We
speed.
believe you. I think we have to also believe the data.
Because of
so
that, yeah. Of course, this patient have a very little calcification, but we can see a calcification between none and left coronary cursor. Almost always, we have PVL in the 1 o'clock at 12 o'clock. The the conjunction, commissure of the left hand and chronic cancer, just like for this patient. So, what do you think? This is not so bad, right?
Yes, not so bad.
So again, measuring the PVL is quite tricky. Sometimes the T is less sensitive, sometimes more sensitive. The AR index is I believe that, but in the patient with AV shunt, like on the hemodialysis, AR index is very low from the beginning because of the AV shunt. So we don't have a really good tools to assess the AR.
This is the last live case of today, so you speak to the audience.
Really? I should have one more cases for today. So, actually we have done the low risk patients on also very complex cases like a valve in valve, and today in the morning we implanted the left main stent concomitantly with the valve placement. So the experience is growing and the valve is improving. So in the future, hopefully, I think we have no discussion for implanting the valve in the low-risk patients. So that's my vision.